Okay, I think we should start. Good morning, everybody. I'm very pleased to be able to welcome you to our expert panel. My name's Rachel Williams. I'm chairing this session this morning. I'm a professor of ophthalmic bioengineering at the University of Liverpool, and I'm currently the interim head of department of the Department of Eye and Vision Science there. This is a very special date, being 6/6/2020. And it has a wonderful sort of symmetry and ophthalmological significance in terms of being representative of normal vision on two different scales. So it's a lovely way to try and celebrate this day and look to see if we can answer some of your questions. I'm going to ask my panel in a minute to introduce themselves to you, but can I just start by discussing a little bit of Zoom etiquette so we can try and make sure that this works well. Please could I ask all of you to mute yourselves unless you're actually speaking, or if I ask you to speak, then perhaps you could unmute yourselves, but generally keep yourselves on mute so that we don't have background noise coming in and disturbing so people can't hear properly. What I would like to ask you to do is to ask questions by using the chat function. So there's a chat box at the bottom, and if you could put your questions into the chat box, I will either pose the question to the panel, or I may ask you to unmute yourself briefly and to ask the question. If I do that, please could you be brief with your question, because we want to get through as many questions as we possibly can, and I'm also going to ask my panel to be brief in terms of their responses so we can get through as many questions as possible. We have a few pre-loaded questions that we've been sent in advance, so we may start with those, but don't be shy, do add your questions when you want. So I think that's it. I think what I'll now do is I'll move on and I'll invite my panel to introduce themselves. So Simon, would you like to introduce yourself, please?
Hi everyone, I'm Simon Harding. I'm also a professor in the University of Liverpool. I'm an ophthalmologist and I specialise in retinal diseases, particularly diabetic retinopathy. Welcome everyone.
Kevin.
Hi everyone, I'm Kevin Hamill. I'm a senior lecturer at the University of Liverpool. I run a research lab that investigates various diseases of the eyes and tries and develops new treatments for things.
Teresa.
Good morning, everyone. I'm a consultant ophthalmologist at the Royal, and my interest is retina diseases, particularly the ones requiring surgery.
Thank you. And Tom.
Hello, I'm Tom. I'm a specialist optometrist at the Royal in Liverpool.
Thank you very much. One of our panelists, unfortunately, has had to is not able to join us at the last minute, but I'm sure we'll be able to use these experts to answer as many questions as you can. So please do start adding questions as you go along, but I'll start with some of the ones that have been sent to us in advance. So one of the first questions is, and I'll put this one to I think this it will come to you, Simon. It says, I'm a patient at St Paul's and have been for many years. The walk from the outpatients to the place where I get the scan is a long one. Can the equipment be moved closer?
Well, yes, eventually when we move to our new hospital. So some of you who are based in Liverpool will know that we're currently working in an old and rather decrepit building, the current Royal Liverpool University Hospital. The eye unit has outgrown this, and we have parts of our service all around the hospital. When we move to the new hospital, which we understand will be in about 2 years now, everything will be much closer. At the moment, we haven't really got any easy solutions for that, I'm afraid.
That's great, thank you. And then the next question is about coronavirus, perhaps not very surprisingly, and perhaps Tom, you might be able to address this. So there's a worry about coronavirus, the eye being a worrying way of contracting coronavirus, and wondering whether that's true or not.
I'm not too sure. I think maybe And anyone else want to go on that one?
Okay. Simon?
Yes, well, we do know that the coronavirus is in the tears. When you blink, you produce tiny droplets that come from your eyes. So there is a theoretical risk of transmission. I think that in truth, amongst the general population, this is really going to be a very, very low chance of anything like that happening. But we're a bit worried in the clinic. So certainly when you come to the clinic, those of you that are, you'll see that we've installed barriers between the ophthalmologist and the patient, so that, and we can clean that carefully between each person. If you wear glasses, that will also act as a kind of a barrier. And those of you that ever have had conjunctivitis, you'll know that certainly if you do have conjunctivitis, then the back of your glasses do get a bit covered with gunk, indicating that stuff does come out of your eyes, at least a certain distance. So the short answer to that is yes, we do need to be a little bit aware of the coronavirus being on the ocular surface.
Thank you, Simon. Teresa, I think this might be a good question for you because it's from a medical student, and they'd like to know what you would say is particularly great about ophthalmology as a specialty.
It is a great specialty because it's very clean. It gives you the option of medical aspects and surgical. There are lots of opportunities for research, and the eye research in ophthalmology has been one. Ophthalmology has provided the opportunity for research in stem cell therapy, genetic therapy, and there are a lot of new avenues that have been happening in ophthalmology. So ophthalmology, the eye being such a small organ, provides different aspects and different diseases, and you can actually identify lots of diseases looking at an eye, which I think is amazing. So yes, ophthalmology is great.
I think a lot of us would say that too. Certainly those of us working in research in ophthalmology, it's a really interesting area to be involved with. So the next question perhaps is a bit more about research, and Kevin, you might like to have a go at this. It's rather a big question. How can we transplant, if we can transplant other organs, why can't we transplant an eye?
That is a big question. And I think that the size of the question probably reflects the size of the challenge. So the eye is great. I mean, it's really complicated and it has lots of different parts that all need to function appropriately. So we can transplant bits of it. You can transplant the front, the cornea, and that's been in the clinic for quite a long time now, and it works really nicely. The problem is that at the back of the eye, the retina is really complicated. It has basically, if you think about it, as a load of different wires that connect to the brain. So while you can fix individual ones, once you're getting up to the fixing thousands of individual wires, you're into quite a messy problem. But that's what we in the lab are working towards. Between various different groups at Liverpool, we're looking at replacing and transplanting either the sheets of cells that support the retina or different parts of the retina, or kind of getting ways around it. So I mean, we're a long way off from transplanting the whole eyeball and connecting it up, being able to get all the wiring right. But we are a lot closer to being able to fix individual parts. Yeah.
Excellent, thank you. Yeah. I don't want us to solve it all at the moment because that's what all the interesting research is doing.
Oh yeah, that's what the rest of my career is about.
Absolutely. Tom, there's a question here for you, I think. So I bought a pair of glasses for a few pounds in a shop for reading and they work very well, but am I damaging my eyes using them? And what's the difference between them and the more expensive glasses that you get from the optician?
Yeah, so the first thing we'll say is that the glasses that you get from a few pounds from the shop, they have a specific set distance between the two eyes. Now everyone's eyes are a different distance apart from each other, And ideally, when you're looking through glasses, you want to be looking through the center of the lens. Because if you're looking a bit off from the center, then you can, if the prescription is quite high, start to cause headaches and have problems from that way. So if you're using the cheap glasses from the shop and you're getting headaches with them, then you're best off getting some from an optician, because the ones from the shop also have the same prescription in both eyes. And as everyone's eyes are normally, there's a bit of difference between the two eyes, you're better off getting the ones from the shop if you get problems with the cheap ones.
Okay, thank you. That's very, very useful. Since I do exactly that, I probably should take notice of that
But with
message.
the ready reader ones, you shouldn't be causing any long-term permanent damage to the eye. That can't happen.
Great, excellent. Simon, there's one here for you. I have diabetes and I'm wondering what are the best steps I can take to stop my sight from deteriorating.
So that's definitely directed at me, that one, seeing I spend most of my time looking after people with diabetes these days. Well, the best way of preventing you getting the effects on your sight are firstly to think about your diabetes control. And we know that good diabetes control and also good control of the blood pressure are very important factors in preventing the eye becoming seriously involved. Unfortunately, most people with diabetes will get a mild type of eye involvement. Then the next thing we recommend is to have photographs every 12 months, which allow us to detect progression from that mild form to the more severe forms, which need more close monitoring and treatment. Then once you have developed the more advanced stages of retinopathy, then it's very important to attend regularly and to pay even more attention to blood sugar and blood pressure control. So overall, it's two factors: controlling your diabetes as best you can and the blood pressure, and secondly, having the monitoring required at your stage of the condition.
Very good, thank you. So I think this question might, I'm going to give it back to Kevin, but I think you might want to sort of pass this on to somebody else as well. So there's a question about someone who obviously went to or listened to Paul Knox's talk earlier in the week, and he mentioned that the brain was the brain that does the seeing, not the eye. And therefore asking a question of, could there be a way of using a camera and connecting it directly to the brain?
So people are working in that direction. There's certainly cortical implants and then chip-based implants that will detect light and convert it into electrical signals. And in essence, that is what your eye does. It takes light in and converts it into electrics. I admit it's not an area I work on. I'm more on the eye side rather than the vision side, but it looks like an exciting kind of development. Maybe Simon will know more.
Well, I can have a go at this, but I think Teresa has also got a good understanding of these implants. So there are various types of implants that are being developed to create artificial sight or electronic sight, as it's sometimes talked about in the media. You can either apply something to the retina, which technically is part of the brain, as I think this question was quite nicely picked up for us. Or you can apply electrodes directly to the brain at the back of your head. That's where the sight set the brain receives the messages of sight, as Kevin has said. So there are some exciting studies going on. So far, people are getting some vision. They can find their way around a familiar space or stop bumping into things. I think the big challenge here is getting electrical signals to connect to human biological tissue. So how do you get a hard material, like an electrode, not to actually destroy the tissue you're trying to connect it to?
Yeah.
So Rachel, who's been spending most of her life working in this kind of area, has, or parts of this area, been trying to develop ways in which you can connect tissue to electrodes with clever materials in a special way that will unlock this new approach to restoring sight.
Yes, I think to add to that, I think there's definitely a materials aspect here that needs to be looked at, which is perhaps the next step in trying to develop this further. Thank you, everyone. Anne-Marie, I'm going to unmute you. Would you like to ask your question? Oh, I don't seem to be able to. Can you unmute yourself? Can you unmute yourself?
Yeah.
That's good.
I have Fuchs dystrophy and just had 2 DMAC procedures. I have been told it runs in families. Is that true? And at what age should my children start having themselves checked for it?
Thank you. Very, very good question. Simon, can you pick that one up?
Yes. So
Fuchs dystrophy.
yes. So this comes in 2 main types, Anne-Marie. Generally speaking, it's something that occurs as you get older. So may I, without being too indelicate, ask you how old you were when this was identified? Initially, when you first had the diagnosis? I think you've muted yourself.
Sorry, you're muted again. Unmute yourself.
I was early 70s, but I had problems for almost 15 years before that. I lost night vision, didn't see colors right, didn't see sharp, and it wasn't cataracts, they said, so they didn't know what it was.
No.
So it was only...
Yes. So, well, this is, so for everyone who is not necessarily familiar with this is a condition of the cornea. Have you had to have a corneal transplant? No, you had a DSEC, didn't you?
I had, a DMAC, they called it here, in both sides.
So that is a very good new development in that field, and there's a nice item on our recording on Wednesday. One of our colleagues, Vito Romano, described the DMEC procedure. So that's probably why you're asking this question. Well, generally speaking, it is something that becomes more common with age. There is some suggestion that it can be hereditary. There is a gene, the COL8A2 gene, which can occur, and that and if you carry that, then you can have then it's autosomal dominant, which means that 50% of your children will be affected. But with most of these autosomal dominant conditions, only affect maybe 10 to 15% of the population. So we usually quote a risk for this sort of type of inheritance of about 15%. Even so, it's very unlikely to affect them much before they are in their 50s. So I would recommend a visit to an optician from the age of about 50 probably. And it can be diagnosed on the slit lamp, as Tom will know. You can see the features on the cornea, the back of the cornea, long before it starts to affect the vision.
Thank you, Simon. I think we need to try and keep answers a little bit shorter.
Okay, I'll take the point.
There's a very interesting question here from Amanda Shaw. I think to you, Teresa, I think you could answer this one. She's recently been signed off following vitrectomy with laser surgery. So how often should she have her eyes checked and where?
Okay, so I assume the vitrectomy with laser was done for the complications of diabetic retinopathy. That is the first reason to do vitrectomy with laser, although there are other reasons. So if after the vitrectomy and if the retinopathy or the disease of the retina caused by the diabetes is stable, then the patients can go back to the screening service on an annual regular basis. If there are other reasons, other changes, and they need to be monitored, then they can be monitored in the hospital locally. So we don't follow everyone here in samples following vitrectomy, but we do give advice and we do refer back to the referring doctor if patients need more laser or they need monitoring for injections, etc. So yeah, there are different.
I hope that helps. Kevin, there's an interesting science question here for you. If you have a corneal abrasion, the cells can migrate over and repair that abrasion over a relatively short period of time. How do the cells know where to go and the fact that they need to move?
Okay, so we've got 40 minutes left. Okay, good. This is we're into my favorite area type territory. There's lots of mechanisms actually. So if you think about your cells as being held together very tightly, it actually means that once you take away part of it, so the scratches, the damage is over here, there's suddenly a loss of contact. And there are various different proteins along the edge of here that can detect that, as well as there's like scaffolding inside the cell that suddenly loses its tension. And so this cell is effectively getting a physical signal that says there's space over here. But there's also cells over in the middle of the wound. So the damage is over here. There's actually factors get released over here that kind of migrate towards or get carried toward the cells on the front. And there's another bunch of proteins on the front that respond to those and then send signals and say, there's a gap and let's move. And it's incredible. And it's so much fun to study. It's genuinely, if you ever want to come visit the lab, I'll bore your ears off and show you videos of this happening all the time. Because if you disrupt any one of these interesting receptors, suddenly your wounds heal a lot more slowly and you end up with recurrent or slow healing erosions and a whole bunch of different problems. And that's basically what my lab works on, and trying to improve the quality of the repair that's happened. Yeah. So the short answer is magic, and the real answer is some amazing biology.
Very nice. And to follow up from that, I think, Matt, really, you'd like to ask a question. So do you want to unmute yourself and ask your question?
Perfect. Morning. So I was just curious, what particular area or field of ophthalmological research do you see being the next big breakthrough and most influential on patient care?
Kevin, you can start, and then we'll go. Well, I think everyone in the panel can have a go at this, a brief go.
From a research side, the stem cell field's moving the quickest. So I think being able to remake the damaged tissue and actually remake and repair. So we had some genetic disease comments about Fuchs dystrophy. It will become possible in the next 20 years. I would suggest that we can repair the genetic defect, replace the tissue that's wrong, and be completely fine. I think that's where science is going. Yeah.
Very good. Simon, would you like to add what you think are your next big
I think we've moved from infection and chronic disease as causes of visual loss to genetic and inherited diseases. And so for me, I think the next big breakthroughs are going to be in controlling vision loss from inherited eye disease, both from the cornea and the retina.
Okay. Teresa, what would you like to add?
I would like to add, in answer to a question, question from yesterday we had about the possibility of treating glaucoma. So is it possible ever to treat glaucoma? We don't know, but we certainly know that studying genes and developing the research on that field, and with the possibility of checking all the genome, meaning all the genes in the body, we can more easily predict which patient will develop certain types of glaucoma and possibly treat earlier, operate earlier. And in that way, yes, we're not going to cure, but it possibly we can change how the disease progress.
And in vision, Tom, what's your next big thing, do you think?
Maybe not less in vision, but I think that the continuous release of drugs through contact lenses could be something really interesting going forwards, and the ability to maybe even monitor things like eye pressure or eye blood sugar levels through a contact lens to give continuous feedback to a hospital about the patient care could be really interesting.
Excellent. That's a really
and what about yourself, Rachel? You need to give an answer here as well.
Well, I mean, I suppose I fit in rather nicely with Kevin's, that I think it's around stem cell material and material interactions with stem cells, and actually developing the materials as scaffolds to support and drive the stem cell response to get the response that you want for the particular application. So that's my area of expertise, although I also work on drug delivery from contact lenses. So it's very nice to hear that as being a really important area. And of course, an infection control. So I actually fit into all of these, except glaucoma. I don't do anything with glaucoma. So, but I think in the laboratory in Liverpool, we have all these different areas where we are progressing different parts of it, including the genetics. And that's one of the huge advantages in Liverpool, is we have the clinical and the non-clinical working together so closely and interacting seamlessly that then allows us to be able to bring the new science to clinical practice in an effective way. In fact, and that fits quite nicely with another question that I've just seen coming up here about intercalating into and training. So a medical student presumably is thinking about training in St. Paul's. What's good about training at St. Paul's? They're hoping to intercalate and they want to know whether this is the best way to do it. Kevin, I think you run the MRes. They're thinking of intercalating in the MRes. I think you could.
I could start off certainly. So from so doing an integrated masters is a great way to get some real hands-on experience and work out what you like. So our MRes works with 3 research projects that are 12 weeks long, 10 weeks gathering data, on which you can do a mixture of things. You can arrange your own project with various different specialties that you care about, but there are also a list of projects that are produced. So with that, you can spend 2-3 projects in the lab doing research-based projects, hands-on at various different stages. You can do, discovery science like my lab does a lot of, or you can do more applied science, which would be, or even clinical research. So that gives you a really nice platform to work out what area you'd like to progress within. But perhaps I could hand over to Teresa or Simon to talk about the clinical progression, because that's beyond me.
Simon, please.
Teresa, you're running the you're quite heavily involved with the medical students these days, I think, aren't you?
Yes, I am. I really, it's one of my passions to get students involved, and because I think students have their own ideas, they are passionate about what they want to do, and it's important that they want to do something they want to do, but they need guidance. And I know from Liverpool there's a group of medical students very interested in understanding how St. Paul's work in collaboration with the university and the institute. And Tayab, who is the president and who is in the audience, he has come up with some proposals that I find very interesting, such as having a meeting, an annual meeting, where medical students are going to present a research project. I know from the college now that there is a proposal for the best projects submitted to the college. They will be interviewed for the podcast. Again, it's a medical student I used to work with in Sunderland, and now he's a registrar and is very involved in the college and is organizing these podcasts. And for entering ophthalmology, you need points. And what the College of Ophthalmologists is considering is to give 1 point for the best projects submitted to the college and interviewed for the podcasts. So if we can, in Liverpool, have this meeting where students can present projects, not only research, basic science, but clinical, I think it would be very interesting.
Good, thank you.
From a points perspective, the MRes is a way to get points, and so are the likely things that will come out of that. So you're likely to get poster presentations, and you probably get your name on a paper ultimately, all of which will contribute towards your specialty points.
Yeah. Just to come back, Teresa, to the vitrectomy surgery question, Amanda says she doesn't have diabetes and she's concerned more about whether she can continue exercising.
Absolutely she can, and she should.
Okay, perfect. I hope that answers that now. Another question about back to COVID and the question of, do we know why or if COVID causes poor eyesight? COVID-19. I don't know who'd like to answer that. Simon?
Yes, so I think most of the effects of COVID-19 at the moment aren't known in the eye. Clearly, the main push of looking after people with COVID-19 has been to try to deal with the pneumonia and getting them through that. But it's just becoming apparent that the prolonged time with very low oxygen is likely to cause some effects in the retina and the nerve. And there are some emerging reports of people who have recovered of having permanent poor sight. So we are worried about that, and we're just launching a study here in Liverpool, which we're hoping to run across the Northwest or even the whole country, to look at people who have been in intensive care and see them 3 months later and try to identify how that's happening. We're also seeing a few people who are recovering with some minor strokes and some other problems with the blood supply to the brain and the heart. And it's likely that the eye is going to be affected in a similar kind of way. So there's a lot to learn still, but the answer is that there are going to be some changes, I'm sure.
Okay, thank you. A question for you, Tom. Somebody who's interested in or is applying to do optometry next year and would like some top tips for going into eye care.
I think if you have an idea of what sort of optometry you might be interested in, that can give you an idea as what you might want to start doing now. So if you think you might be interested in doing hospital optometry, then maybe try and get in touch with your local hospital and see if they'd take you on for a week or 2 weeks, get some experience what that might be like. When it comes to actually, if you want to do hospital optometry as a career in the long run, then I just advise when you do your pre-registration year after university to apply for a pre-registration in the hospital, and then that'll take you forward from there.
Very good, thank you. Actually, there's another question for you, and I guess it sort of is back to the measuring of with contact lenses. So can you tell from somebody's eyes if they have diabetes or high blood pressure? Perhaps how would you go about trying to do that, Tom?
So it's something which in a routine sight test, if there is diabetes that's causing some form of retinopathy, that you may be able to detect. And similar with high blood pressure, there are some signs at the back of the eye which could be found during a routine sight test, such as your blood vessels may be a bit more wriggly or a bit more curvy than normal. That can be detected in a normal sight test with high blood pressure. So it's something which can be detected in certain stages, but very, very mild diabetes or high blood pressure is not a guarantee it would be picked up from a routine sight test.
Okay, thank you. A question about potential side effects for corneal transplant. Could this include stroke? And then treatment of this including aspirin, and whether there's any link between the link of using aspirin and cataracts. Simon, I think.
Yes, I'll give this my best shot, but I'm hoping Teresa might bail me out here as well, saying we're both retina people.
I think we're missing Mark here.
We are missing Mark, one of our great friends and colleagues who hasn't been able to join us at short notice. I'm not really aware of a corneal transplant having any direct effects on the retina, apart from general, any sorts of complications that can occur with any operation, such as hemorrhage or an infection or some other such indirect effect. Aspirin as a way of controlling the effects on the retina and on stroke. Well, aspirin certainly has is thought to have a beneficial effect on stroke. We do usually recommend a low dose aspirin for anybody who's had any occlusion of their eye or brain vessels.
Is there a link with cataract for aspirin though?
Well,
I've never heard of it. No.
I haven't heard of that either. I know that there were a lot of studies in the 70s and 80s on that, but I don't think that ever really showed a relationship. But whoever's asking the question might know something more than I do. I'm now going to deflect this to Teresa. Do you have anything else to add?
No, I don't. I would just agree with you that the changes that we might see in the retina are indirectly related. So if we do a corneal transplant, any operation causes inflammation in the eye. And so inflammation can manifest in the back of the eye with swelling. So that's why patients after operations can come to a retina clinic, because they need to be treated for this swelling in the back of the eye. But yeah, it's just inflammation caused by any operation, including cataract.
Let's move on to this question that we were sent in advance about genetic counselling. So the question is that it's very valuable to people, but it's not always quite clear how to get involved with it. And there's a concern that people living with sight loss, they don't always understand the extent to which there is a genetic link and how it might affect their families. So what is the process for getting genetic counselling for people if they've got a genetic eye disease, and how would they go about trying to organise that? Simon, can you answer that one?
Yes, I'll try to cover that. So we do have genetic counselling services. They are a bit patchy across the country. They also occur in many other countries, and as there is more knowledge and more treatment for genetic diseases, they are expanding. The question really is about access, and typically the access would be at the point that a person receives the diagnosis. The trouble is you might have had the diagnosis in your teens or 20s, and then you're wondering when you're 40 or 50, there's been so many new breakthroughs, how do you get access again? So most of the larger clinical centres run genetic clinics, and most of us keep a permanent record of everyone with these diagnoses. So, but if that doesn't trigger an access, then I think the sensible thing is to ask for a referral to a specifically recognised ophthalmologist with knowledge in genetic diseases who can access the counselling services. In Liverpool, it's at the Liverpool Women's Hospital. That's because most people with genetic diseases have it diagnosed at birth, and that's where most of the neonatal genetic diseases are picked up.
So if they say they had a family member who was then, didn't have a problem with their eyes, but wanted to know whether there was a risk of starting a family, for example, would they go via their GP?
Well, the way we normally think about genetic diseases is families. And so at the point of the person being diagnosed with the condition, part of that diagnosis is to take a family history and make a record of everyone who's at least a first degree relative, so parents, brothers and sisters and children. And typically we would offer an eye examination at that point for all of those people. So I think that, again, going back to a clinic that's used to looking and providing investigations for families is a good starting point, because most of the conditions that we can diagnose at the moment are detectable by an eye examination. So then that would be a good starting point, I think.
Okay, let's move on to another question. So how much of a problem do you think infection is after eye surgery? Teresa?
So it's very rare. We state less than 1 in 1,000, but it is, we cannot neglect that, because when it happens, although it's very rare, it can be devastating. So it's part of the consenting and counseling patients. So it's really important. And a cataract operation, people, and we all think cataract operations are easy. Yes, they are easy, because everyone has become very good at doing cataract operations, but there are risks. So people should have surgery if they really need surgery, not to prevent.
And would you, as standard, give antibiotics after surgery, just as a prophylactic, for example?
Yeah, we do. Yeah.
And do you think then there's a risk of that leading to antibiotic resistance?
There is, and I know some centers, for example, some other departments, instead of giving 2 weeks, they give only 3 days. And after injections, for example, and again injections, it is called anti-VEGF that patients with macular degeneration have. We don't give antibiotics after injection, but we make sure we clean the eye with iodine, which is more effective than the antibiotics, really.
Mm-hmm. Okay, thank you. Tom, I think this question is coming to you. Can you train or exercise your eyes so that you don't need to wear glasses?
You can't train them so you don't need to wear glasses. So if your vision's poor and glasses can correct it, the only way to correct it is from using glasses. There are some eye conditions more to do with the movement of the eyes, whereby you may be given eye exercises by an orthoptist or an optician, whereby when you read and look at things up close, if you get very mild double vision and your eyes are strained when they're tired, you can then train them to work a little bit better. But that's more when you're younger. Whereas if you have a problem where you actually need to wear glasses, there's no training that, so you don't need to wear glasses.
Very good, thank you. Very clear.
Yes.
There's a question about a blog that was written recently by our colleague who's just retired, Deborah Broadbent, about removing metal fragments that have lodged in the eye. Teresa, I think this question may come to you really, because it's talking about metal fragments in the vitreous, I think, and using a magnet to try and remove it. Is this still possible? I mean, is this really possible, and is it still used today?
Yes, I think that blog related to a big magnet that then causes a large magnetic field, and you would, in the past, you would use that if the magnetic foreign body was loose in the eye, because if it's not, then you pull everything out of the eye. But so developing from that, we can still use magnetic magnets, but small ones that go inside the eye, and use the principle of the foreign body being magnetic, and that is related to the property of the foreign body. But nowadays we use forceps through a vitrectomy, but there are smaller magnets with smaller magnetic field. The ones that the retiring doctor mentioned too, yes, it created a large magnetic field, and it could go, could stuck anywhere.
Very good, thank you. Keep your questions coming in, guys, as we've still got plenty of time, and our experts are here. Tom, there's a question about the eye puff, and people don't like eye puffs.
Yes.
What can you do instead?
So there is an alternative that can be done that requires an anaesthetic. The benefit of the eye puff is it's a really quick, fairly accurate way of getting the eye pressure, not as accurate as the gold standard that we might use in the hospital. Particularly pertinent at this time because our body, the College of Optometrists, have recommended in routine practice that we stop using the eye puff for the moment, because they say it may release COVID-19 from the tears into the air. So at this period in time, they've been advised on the high street to not use the eye puff tonometry. You may find them using other methods instead. But for routine sight tests, it's definitely something we recommend, because it can pick up maybe the early stages of glaucoma, which could be one of the indications that there's something going wrong with the back of the eye. That's predominantly found early on when the pressure in the eye is higher. So if it's something you're just afraid of, I'd say still have a chat with your optometrist about it, but still, if you can, go ahead and have it done, because it's a very important part of the sight test.
Absolutely. moving on then, or carrying on in this question of glaucoma, I think, and Teresa mentioned earlier about, we're unlikely to find a cure for glaucoma, but what are the next big advantages or big advances? I mean, I think, Kevin, perhaps, what do you think we can do in the lab to really progress the treatment of glaucoma?
So, well, I can speak directly to one of our projects where we're trying to prevent progression by targeting the proteins that are causing the problem. In glaucoma, the real problem is that the drainage channels in the eye get filled up with gunk, and they are all turned on by a certain set of proteins. So what we think we can do is turn down that protein so that less of it gets made and we get less gunk being produced, and that would stop the disease from worsening. Now, other people in a different group in the lab are working on a replacement therapy. So once you're filled up, once the drainage channel is filled, it kind of the cells die off. And so one of the groups in the lab are working on making the cells so that we can then replace them and get it functioning again, which would, in that situation, would not just prevent worsening, but would probably start to, well, it would repair the cause of the damage. The retinal damage, unfortunately, once it's happened, that's harder to repair. So it's much better to get things early, which, picking up on Tom's message, is that's why you want to find out as soon as possible that you're at risk so that we can begin to prevent the worsening or prevent the damage from happening. So from my angle, that's the two big sort of directions. One's kind of genetic, one kind of physical replacement.
I'm sorry, just to add another dimension to that. So could you pick it up earlier, or how could we pick it up earlier before you get an increase in pressure?
So you certainly, I mean, from when there's genetically inherited, we could become aware of risk factors, and we could begin to sort of pre-screen people in that sense. The thing is that the pressure change you see is only one form of glaucoma. Although it's the biggest risk factor, it's not the only cause of it. So the genetic screening might become the answer. Yeah.
Thank you. Sorry, that was rather difficult, but I just thought it was worth taking that one further forward. Simon, there's an interesting question, and I think you could address this, and you're involved in some of these projects, about the impact of artificial intelligence on the future of ophthalmology. Would you like to address that?
I just read that from Tayab. Thanks for a really interesting question. I think the answer here is it's going to have a big impact, but it's going to be a bit slower than we think. And that's because for artificial intelligence to work properly, you need huge amounts of information. And so there aren't quite so many conditions or parts of ophthalmology where that's possible. Anything where there's lots of photographs, or where there's thousands and thousands of patients attending, so lots of the common conditions like diabetes, it'll be a good aid in diagnosis and in automatically interpreting the images. And then the other point I want to just, that I've been realizing with this is that people are not very comfortable about being told about recommended to have a treatment based on a computer's decision. And that's, just as we're seeing with COVID-19, there's lots of uncertainty, isn't there, about everything we're being told. And AI is just as semi-intelligent as everything else that we're learning to live with. So there's always going to be a place for a human. So I think probably the impact will be humans and computers working together.
Yeah, and I can just add a little bit to that. There is a lot of hype about artificial intelligence, which is perhaps quite confusing, and certainly colleagues of mine in more of the engineering computer science field are highlighting a lot of problems with artificial intelligence when you don't have all the data and decisions being made with not all the data available. And I think it's very important that people understand that it's not going to be a panacea for everything, and just to keep that in mind, even if some of the newspapers are trying to tell us that it's going to solve all our problems.
Yes, if one thing hopefully that might have come out of the dreadful pandemic is that people are starting to understand the concept of uncertainty.
A question again, Taib, thank you very much. There's another question about surgical simulators and whether these could help trainees and how good they are at that in sort of as being as a training aid. Perhaps Teresa, can you address that?
Yes, I'm very in favor of that. I shouldn't answer these because I have conflict of interest in this because I'm working with Tayyab in trying to get the IC, which is a surgical simulator here in Liverpool, so that the trainees and 20 centers in the country have had the IC. There was a recent report on the British Journal of Ophthalmology reporting a reduction in complications, the complication rate after cataract surgery if trainees practice first on the IC. That is very relevant now in a COVID situation where there's less opportunities for trainees to operate. Students, medical students wanting to apply for ophthalmology, having the experience of the simulator, that can be added on their portfolio. And I worked in Newcastle University and I was part of some workshops with medical students there, and they had access to an eye simulator in Newcastle in the eye department there. And I think it would be very useful for everyone and the medical students, the engagement, if we pushed for one here. That's my opinion.
That's a good plug.
That's a very good plug, yes. I don't know who does anybody know about kaleidoscope migraines and whether they're associated with vitreoretinal surgery? Teresa, Tom?
There's no evidence that vitrectomy causes migraine. However, if someone has an operation that is a source of stress and there are inflammatory factors and some other factors are released in the body that can cause spasm of the vessels, because migraine essentially is a disease of the spasm of the vessels and inflammation. So could it trigger migraine? I suppose it could, but there's no direct link saying vitrectomy is a risk factor for migraine.
And I guess as the inflammatory response quietens down, you would expect to get less of a risk of it. Yeah. An interesting question about the fact that England's now moved to an opt-out system for organ donation. Do you think that's going to increase the numbers of cornea available for transplant? I guess right now it's a problem with COVID and not being sure whether COVID's a problem with transplanted cornea. But any evidence that or do you think that they will get more cornea available for transplant, do you think?
I think so. I was just looking to see if there were any statistics, but I couldn't find any just between seeing the question and it coming up. But previously, there was a significant waiting list of people of people needing corneal transplants because of a lack of supply. And I am aware that has dropped in recent in the last 12 months since the opt-out system came in. Teresa will be able to tell us about the situation in other countries as well. We know that in Spain there's been a big increase in supply after the opt-out was introduced. So I think the answer is yes, but I can't quote statistics to support that.
No, I guess it's quite early still. Okay, so a question for Tom about low vision assessment. Can you talk about what's involved in a low vision assessment and any develops in new vision aids that are available?
So the way a low vision assessment may differ from a sight test that we know that you'd go for regularly is a low vision assessment that have a much more comprehensive case history, and there might be quite a few more personal questions involved about your home environment, about who you live with, and about sort of what hobbies and things you like to do. So one of the first things we might try and do is maybe set 2 or 3 goals that we could try and obtain in this low vision assessment of things that, because of your sight loss, you may be unable to do at the moment. And we'd hopefully have you by the end of the low vision assessment with some magnifying glasses or other devices to try and help you achieve those goals that you'd like to be able to do. In terms of any new developments in the low vision aids sort of industry, the way it seems to be going at the moment is more based around electronic low vision aids. So there's some really good kit at the moment which has lights involved, and you can change the contrast on a screen to really boost the size and the visibility of the print. So I think going forward, if you do have problems with your vision, try and get involved with using electronic devices as early as possible, particularly sort of iPads and phones. If you can get your head around those early on, then going forward you'll be in a good place.
Perhaps that's a good point to make a suggestion that some of the people on the call might not be as familiar with the chat function. So maybe we could open up some questions to the floor if anyone wants to.
Okay, absolutely. Let's let me just ask this. There's another question just come in, and then we will open it up for the last little bit, shall we? So first of all, a question about corneal transplant and how long you might expect to have to wait after a corneal transplant for your vision to improve. It might be rather a difficult question because I suspect it's very dependent on why you've had the corneal transplant, but also about coping with the vision loss during that time. Simon, can you pick that up at this stage?
Yes, it's a long time since I've done corneal transplants, but I did run a corneal transplant service for a while. I seem to have frozen there.
No, you're okay, you're fine.
Okay, I'm still
Yep.
Audio is working even if video isn't. Well, with the more recent techniques, the rehabilitation is quicker. It always used to be said that it was 3 months before you really had a feel as to what your vision was going to be like. Most of the time when you have a corneal transplant, it does change the glasses prescription quite substantially. It takes time for the new transplant to clear, and then also for the shape of the eye to settle down. There needs to be a bit of adjustment typically during that period, which you can't start introducing into the post-operative care for at least 6 weeks after the procedure. So I think a sort of general rule of thumb, 3 months before you really know whether you know what the vision, how successful the operation is going to be. With the DMEC, DSEC, and other incomplete operations, then quicker than that. Sometimes for some people, it can be up to a year before you really know what the outcome is being, particularly if there's a little bit of rejection or some other problems that have to be looked after. So it is a long haul for quite a lot of people.
Thank you, Simon. Okay, I tell you what, I think Kevin's idea is a very good one. So if there's anybody who can't or would like to ask a question but hasn't managed to because of the way we're using the chat function, if they'd like to unmute themselves and ask their question, if you all ask at once, then I will try and manage it in some way. But if anyone would like to ask a question, please do. I think you'll have to unmute yourselves because I can't seem to unmute you all at the same time. No?
Yeah, I already asked about Fuchs dystrophy. How come that most of the opticians I have been to, and the one I'm now visiting when I need new glasses, never heard about it?
I'm sorry, I missed the last bit of that. Could you just say it again?
They never heard about Fuchs dystrophy.
So they don't know about it.
What was wrong with me? Sent me in the end to Wigan Eye Hospital, Eye Clinic, where I was told it was Fuchs dystrophy and was given glaucoma drops and was on them for 6 years.
I'm going to pass this to Tom, because I think this is a question of opticians and knowing, you know, how is there a problem with people not knowing what their problems are?
In terms from a patient's point of view or from the optician
Well,
themselves?
from the optician, it seems like they didn't have enough information to know that it was Fuchs dystrophy from the assessment they'd been able to do in the optician. So are they not? Do they not have access to the right tests?
I think it's maybe more to do with perhaps the high street optician has to have perhaps such a broad range of knowledge that maybe some more specific diseases they find it perhaps a bit harder to screen for. There's no reason with the correct level of knowledge why you shouldn't be able to pick it up on the high street. It's something which you can see with a slit lamp, and should be able to diagnose if you have the right level of expertise to be able to see it and have a rough idea of what the condition is and maybe if someone else needs to see it or not. So it's something which should be able to be spotted.
It is part of the core knowledge that all optometrists have, isn't it, Tom?
Yeah, definitely. Using a slit lamp and being able to detect corneal problems is something all optometrists should be able to do on the high street.
And Fuchs corneal endothelial dystrophy is a common enough condition.
I was going to say, it's not that rare, is it?
No, it's not. It is not a rare condition. I would call it sort of uncommon rather than rare.
It sounds like you were unlucky, Anne-Marie, that you didn't find an optician that knew what they were looking at. And
yes, I think that's probably the
I
case.
think so, but even after my operation, I had to explain to them what it was.
Right. Okay.
Find a new option, find a different one.
Yeah.
Yes, I think that's probably the case.
Yeah, weird. Okay.
It looks like
Sorry, go on, Kevin.
it looks like Aileen and Phil Morgan might have a question.
Please ask your question.
Yes, I am quite surprised that AMD hasn't been mentioned a lot. Though this is the highest condition at the moment for blindness. A lot of my family have it, and I did a questioning because and we're all females that have got it, and we've got daughters and granddaughters, and our great concern is that we know that some of them will get it at the moment unless there's a big improvement in prevention, and you know, I'm looking out for something in the near future that might happen in that field.
Simon, you could offer.
So thanks very much for asking that question. It's funny how sometimes the commonest conditions don't get asked about until right at the end, but it's just the way that the random nature of these things. So age-related macular degeneration is the commonest cause of visual loss in the country. We've done really well in England and Wales, well, in the UK, because our National Health Service has granted access to everybody without having to pay for it for an incredibly expensive treatment. The intravitreal injections that Teresa mentioned about half an hour ago, the anti-VEGF treatments. So that has had a huge impact on the amount of blindness that there is, but there is still visual impairment. I'm afraid that we haven't got a way of preventing it yet. This is one of the conditions that is most strongly associated with families. We think that 98% of the reason you get it is because it's passed down through the family in some way. And there's been a lot of work in Liverpool, in fact, on that. So it is very important that people's relatives, particularly their brothers and sisters, are examined on a regular basis by most optometrists. Have a scanning system that can detect it early, and that the children of people that have been treated for macular degeneration are also seen, and normally we recommend from the age of 50. The treatment is much more effective than it was just 10 years ago. So although we can't prevent it, there's a lot we can do about it, and there's a huge effort going on the treatment. And Kevin is waving. He's going to add some science side of this.
So one point of this is that, as Simon said, AMD is very often a genetic disease, and it is there's a long lead period. So this is where the bench-based science actually has a lot of potential. So the big things that are happening at the moment are gene therapy, where the genetic cause of the disease can now begin to be repaired. Now, a lot of that is still in a dish or in a model system at the moment. But if you're talking about grandchildren or even children, and you're talking a longer lead period, that will be the future, where we will identify the cause of the disease and be able to repair it before the damage happens. So I think AMD is one of those diseases where there is really important research going on right now. That is it's a ways away from the clinic yet, but I think there's hope for the future. I think it's a really it's an important disease that is being addressed, because it affects a lot of people.
Yeah.
Good to hear. Thank you.
So just a question, sort of back in the chat box, actually, about the aging population and what sort of challenges that is going to bring to places like St. Paul's over the next decade or so. You know, because there are going to be a lot more of these patients, AMD patients, coming forward, and as Simon says, it's very expensive. How are we going to, Simon, how's St. Paul's going to manage this sort of thing?
Well, I'd be interested to hear what Teresa's got to say on this as well, because she's going to be dealing with these for longer than I am. Yes, the numbers have roughly doubled in the last 10 years. The numbers of people coming to the eye clinics have doubled, and the amount of money spent on eye care has doubled in the last 10 years. So the first question is whether it's going to double again. Well, the number of people needing treatment is going to go up. I am really hopeful that we will make some breakthroughs on the numbers of times people have to come. Currently, we're not very good at curing things. In fact, there are very few things that we can cure. So most of the time, people have to keep coming for the rest of their days. So if we can make some breakthroughs in curing disease and stop people having to come, that will counterbalance the otherwise probably inexorable increase, and we'll have to have another St. Paul's and another one and another one.
Yeah, Tom.
I think what could be really useful from a hospital point of view as well is utilising optometrists to maybe see some of the more routine work that doctors are doing. So then that would free up the doctors to be doing more complex surgeries.
Yep, that's a very good point.
And also, I think some of the work that you're involved with, Simon, in relation to working out when people actually need to be brought back in for screening, for example, I think will be very, very important. And rather than having people routinely coming back every 6 months, some of them you may not be able to need to see for 2 years, would clearly be better for the patients and better for the hospital. And that's something we need to do.
It's worth mentioning Paul Knox's work just now, because we've just had the AMD question as well. So one of our vision scientists at the university is working on a handheld device to track your vision to detect the early stages of age-related macular degeneration. So he's looking to push that out to be an app that people can download onto their cell phone and just tap away and kind of pushing even more stuff before the clinic, which is going to help.
Teresa, did you want to add anything on that?
Yes, for the short term, I think we're going to see an increase of patients because there are studies that now are suggesting treatment for dry age-related macular degeneration to prevent progression. So that's going to be another challenge. Secondly, I think in 10 years' time, possibly, or 15 years or maybe less, that would be ideal, we'll be wondering why were these patients coming to have injections every month, because it would be ideal if we could treat some other way with contact lens and drops delivery, because I don't think it's sustainable to keep injecting forever all these patients. It has to be better.
So there's another question in the box about contact lenses and I think this is the question is particularly about the help the contact lenses could be after corneal transplant. But actually, I think this is a more general question, or could be turned into a more general question in relation to some of the stuff that I'm involved with. Is we can actually develop materials to make contact lenses that have the potential to deliver drugs of different sorts, and either anti-infection or glaucoma or possibly anti-inflammatory, for example. And would that be useful? And what is the control that's needed to make those so that they're useful to the patients? I mean, maybe Tom, you brought up the contact lens drug delivery systems. I think from a research point of view, we need to know what it is that would be really useful to you and how much control you need.
I think it's being able to get the drug into the eyes and keep the patient having a good usable level of vision. And I don't know the controls. I'm not sure who manages the drug controls for.
Well, it's more about the controlled release. I mean, if you had a contact lens that released for 12 hours, is that sufficient, or do you need it to release for 4 weeks? And if they need to release for 4 weeks, then the material properties of that has clearly got to be very different, because you've got to have something you continuously wear for 4 weeks. And how would patients manage that themselves?
Yeah, it's a very good point. And I imagine it partially would probably depend on what the drug is for and what condition you're treating with it, because some you might only want in short bursts or short periods of time. And then the advice at the moment is not really to be sleeping in contact lenses unless they are really, really high quality level of oxygen going through them. And even then, you're still putting yourself at greater risk of getting a corneal ulcer.
Yeah.
So if there's a way of doing it whereby the patient can only wear the lens during the daytime for a limited number of hours, and then the drug wouldn't be used at night, then that would be the way forward, I think, maybe with that.
Any other questions from our esteemed audience? No? Well, I think we're actually over our time now. I think it's been extremely useful meeting. I think we've covered a lot of a very broad area of both science and clinical practice. And I think I would just like to thank you all for attending, and particularly to thank my panel for being so good at answering questions which may not have been directly in their field of expertise, but doing an extremely good job. So thank you all very much. This will be has been recorded and will be uploaded somewhere. Tom will sort that out. I guess it'll be on the Eyes Revealed website, and will be available for any of you to go back to at any time if you'd like to follow anything up again. But with that, thank you very much, and I hope you all have a very nice weekend. And don't forget to celebrate 6/6/2020. It's such a wonderful date.
Thank you, Rachel, for hosting.
Thank you, Rachel.
Yeah.
So well.
Very
Thank
good.
you, Tom, for organising the event.
Thank you, Tom. You've been in the background, but you've been working very hard.
Thank you all. I will close the session.